So good evening, everybody. This is Francesco Sanguedolce from Barcelona, from the Suputret. I'm a urologist with special interest in prostate cancer. I'm also the chair of the imaging section of the EAU. And it's my pleasure this evening to introduce you this very interesting webinar with very prominent speakers from all over the globe. And it would be my pleasure, first and foremost, to introduce you Professor Jocelyn Serolin. He's a professor from the University of Strasbourg in the Institute of Genetic and Biology, Molecular Biology from Strasbourg. So Jocelyn, if you want to say hello to everybody. And
hello, everybody.
Yeah, so it will be obviously very pleasure to moderate with you and this webinar, which is entitled as a New Precision Medicine Opportunities in Advanced Prostate Cancer, from molecular understanding to treatment targeting. This is a very hot topic in nowadays in advanced prostate cancer, especially with the changing of the clinical scenarios and the treatment opportunities in the hormone sensitive setting. And so far, there are new research that have been done in the later stages of prostate cancer, especially with the investigation of new pathways or cellular and prostate cancer cells in order to find other targets and in order to provide to patients in the castration-resistant setting more precise treatment options. And while waiting for the attendees to join us, we already are reaching the 100. I will briefly introduce all the speakers, and obviously we'll alternate with Professor Serolin in introducing the actual speaker, the actual topics. So today we'll have Professor Avida he's a Director of Translational Research on Prostate Cancer from the Sloan Kettering Center from New York. We'll have also Professor Maria Giulia Kanji as Associate Director. She is a geneticist and biologist in the pathology unit in Milan, in Hospital San Raffaele. And last but not least, actually, Professor Stefano Fanti from Bologna. He's a full professor in nuclear medicine and obviously a prominent speaker and knowledgeable investigator in terms of theranostics. I don't want obviously to spend more time in useless words, and as the main topic will be covered by these prominent speakers, so it will be my pleasure first and foremost to introduce again Professor Avida, and who's going to talk about mechanistic background of efficacy on PARP inhibitors in combination with new anti-androgen agent in patient without HRR, which stands for homologous recombination repair mutations. Thank you very much, Dr. Avida.
Pleasure to be here. Thank you, Dr. Sanguedolce. It's my pleasure today to present on this topic, which is really PARP inhibitors in combination with next generation hormonal agents in patients without HRR mutations. This is my disclosure slide. And I'd like to start by showing this simplified slide summarizing some of the key DNA repair pathways in both normal and cancerous cells. So as we know, cancer cells undergo different types of DNA damage in response to various stressors and is not part of normal DNA replication, cell division. And one of these key pathways that is relevant to the discussion today is homologous recombination repair, which is circled in this red box here. What this pathway is directed at is the repair of DNA double-stranded breaks that is high homology, and it involves certain genes and their protein products that are represented here, including BRCA2, BRCA1, which we will refer to repeatedly, RAD50, 51 homologs, as well as some indirectly related proteins, including ATM and CHEK2. And we'll get back to that topic as well. Now, the reason we're interested in DNA damage repair is largely due to this large study that was published in 2015 in Cell by a international group funded by Stand Up to Cancer. This study looked at genomic profiling of 150 men with metastatic castration-resistant prostate cancer. And one of the notable findings was that a substantial proportion, about 15 to 20%, had deleterious genomic alterations in DNA repair genes that were largely homologous recombination genes. That includes BRCA2, featured at the top at 13% frequency. And of course, we've known that targeting of BRCA2 mutated cancers could be effective in ovarian cancer, where there was an approval for the PARP inhibitor, olaparib, for several years. And so, of course, this naturally led to the question of, can PARP inhibitors be effective selectively in the situation where a cancer cell exhibits BRCA2 alteration? And so by extension, we would consider it to be homologous recombination repair deficient. That is the biomarker for homologous recombination repair deficiency. And so this led to really two key studies. The first is Triton-2, which was a study of rucaparib as monotherapy in metastatic CRPC harboring mutations in BRCA and other homologous recombination genes. And just to really summarize, that the study met its primary endpoint of overall radiographic response in the BRCA mutated cohort. That response rate here was ranged from 45 to 50%, depending on who was reviewing the scans, with a PSA response rate of approximately 55%. And this met its primary endpoint, and this drug, rucaparib, was approved by the FDA in 2020 for BRCA mutated metastatic CRPC. And of course, the other key study is PROfound, which is a large phase 3 randomized study of olaparib, another PARP inhibitor, as monotherapy versus a physician's choice second-line therapy in metastatic CRPC. The study also met its primary endpoint, which is shown here in the Kaplan-Meier curve, showing a radiographic progression-free survival benefit for olaparib versus physician's choice therapy with a hazard ratio of 0.34. And this led just a week later to the second PARP inhibitor approval, at least in the United States, in prostate cancer. But again, this was in selected metastatic CRPC harboring certain mutations, most prominently BRCA2. Now, of course, that's not the topic of discussion today. The topic of discussion today is the combination of PARP inhibition with next-generation hormonal therapy in a non-homologous recombination deficient setting. And that is an area where there's less preclinical data, certainly does not fit the paradigm of synthetic lethality that we know of for PARP inhibitors. So I'm going to present the mechanistic background for this as well as the clinical data behind this. And I'd like to show you two key preclinical studies that are often referenced for the rationale. The first is the study by Asim et al., which was published in 2017 in Nature Communications. And I'll show you really two key figures that sort of summarize the main message of the study. So at the top left here, what's called panel B, the investigators looked at a preclinical model of prostate cancer. This was a LINCAP derived cell line model. And what you can show here is they expose the cell line to DNA damage with ionizing radiation, which provokes double-stranded DNA breaks. And what you can show is with increasing amounts of ionizing radiation in the black bars, you can see the accumulation of RAD51 foci, which are really indicative of homologous recombination throughout the genome. What you can see is this cell line has an isogenic low androgen receptor counterpart in the white bar. What you can see is that in low androgen receptor levels, there is not a similar accumulation of RAD51 foci in response to DNA damage. So you can see that low AR seems to inhibit the accumulation of RAD51 foci in homologous recombination. Now, the bottom panel, what the authors did here is they exposed cancer cell lines C4-2 and LN3. These are AR-positive cell lines to olaparib by itself, and that did not cause cell killing. However, the combination of olaparib plus AR inhibition, they used both the old generation bicalutamide as well as the next generation drug enzalutamide. The combination seems to cause cell death. So the conclusion here was that AR modulates homologous recombination repair, and that the combination of PARP inhibition, which provokes double-strand breaks, with androgen receptor inhibition it causes cell death in these preclinical models of prostate cancer. The second key study that's frequently cited as the rationale for this combination is this study by Lee et al. From the group at MD Anderson. And they use different cell lines here. Again, very frequently used cell line models of prostate cancer, VCAP, LNCAP, and 22RV1. What they show here is that there is some modulation of homologous recombination genes by inhibition of the androgen receptor. So in the panel all the way on the left, you can see VCAP. When they use enzalutamide, there's downregulation of homologous recombination genes, and the combination of enzalutamide plus olaparib appears to do the same thing. This is variable depending on the cell line, but all in all, their conclusion is that the combination of AR inhibition with enzalutamide plus olaparib causes downregulation of homologous recombination genes. And consequently, they did this xenograft study shown at the bottom panel, where they show that you get some inhibition of xenograft growth with either enzalutamide or olaparib alone using this xenograft model of prostate cancer. However, when they use both a lead-in of AR inhibition with enzalutamide and then add on olaparib, in the black line, you can see profound suppression of xenograft growth. So the conclusion here is that in some laboratory models of prostate cancer, some of these most common ones are LNCAP, VCAP, and others, which are really not thought of particularly as being homologous recombination deficient, that the inhibition of androgen receptor results in downregulated expression of homologous recombination genes and inhibition of homologous recombination itself as measured by RAD51 foci, gamma H2AX foci, and others, which I didn't show here. And consequently, there's some data from these particular studies to show that combination of AR inhibition with enzalutamide and a PARP inhibitor inhibits the growth of these cell lines and xenograft. Now, of course, I'd like to end this with caveats that, cancer cell lines do not necessarily always represent the behavior of human prostate tumors. Particularly, these cell lines have been passaged really since the 1990s, so it's unclear if they've acquired a certain level of homologous recombination deficiency. That being said, I'd like to move on to clinical studies supporting the combination or refuting the combination. The first one that led to broad interest in the combination was this phase 2 study that was happening concurrently with the previous preclinical studies that I mentioned. This was a randomized phase 2 study of abiraterone alone versus abiraterone plus the PARP inhibitor olaparib in advanced metastatic CRPC that had been treated with a next generation hormone agent as well as taxane chemotherapy. The key elements here is that this is an unselected study that really enrolled all comers, and a stratification by homologous recombination status was performed in an exploratory manner. It was done retrospectively using cell-free DNA samples, which we know has its own limitations in terms of identifying certain DNA repair mutations. So again, unselected phase 2 study, all comers, exploratory stratification by HR status. The key findings of this study really are represented in these Kaplan-Meier plots. So I'll direct your attention to panel A at the top left, which really overall the study seemed to have a benefit for the combination of olaparib and abiraterone in this all-comer study with a hazard ratio here of 0.65. And then I'd like to direct your attention to the bottom left panel, panel C. Now, this is, again, exploratory in the group that was considered non-homologous recombination deficient by cell-free DNA analysis. And although this numbers were small, there appeared to be a potential benefit in the combination arm, again, in these patients who did not have any identifiable BRCA or BRCA-like mutations by cell-free DNA, but again, exploratory. And this has really led to the key study looking at this combination of olaparib and abiraterone versus abiraterone alone in first-line metastatic CRPC. This was the PROPEL study, a large phase 3 study, international study looking at the combination versus abiraterone alone in first-line metastatic CRPC. Just like the phase 2 study, this was an unselected study. It did allow prior treatment with a next-generation agent or docetaxel for metastatic castration-sensitive disease, but very few patients had gotten a next-generation hormonal agent. So this is really predominantly patients who are naive to abiraterone and enzalutamide. This group of patients is becoming less common in metastatic CRPC. And again, the DNA testing was exploratory and retrospective, often done via plasma or cell-free DNA testing. The study met its primary endpoint of radiographic progression-free survival in the overall population. they did report the exploratory homologous recombination wild type or non-mutated subgroup, and there appeared to be a benefit in this subgroup. But again, the study was not designed for this, it was exploratory. This study was published in the New England Journal in 2022. Now, we have to contrast this with the other key study here, which is the magnitude study. This study looked at niraparib, a different PARP inhibitor in combination with abiraterone, again, in a similar patient population, metastatic CRPC. Prior treatment for metastatic castration-sensitive disease was also allowed, but very few patients had gotten actually next-generation hormonal agents. So again, predominantly patients who are naive to abiraterone and enzalutamide. The key design difference here is that this study was designed in 2 cohorts prospectively stratified by HR status. So there was an HR positive cohort, BRCA and BRCA-like, and an HR negative cohort that were prospectively selected. And the key difference in the outcome here was that in the HR negative cohort, again, prospectively selected, there was no benefit for the combination. Enrollment ended early at the time of futility analysis, where futility was declared with a hazard ratio of 1.10 approximately. And this was a similar endpoint of radiographic progression-free survival. So a key difference in results here for the combination of a PARP inhibitor plus abiraterone in first-line metastatic CRPC in the HR negative population. And lastly, I'd like to move on to the TALAPRO-2 study, which was only reported at GeoASCO this year in early form. It's not been published yet. This was a phase 3 study, again in first-line metastatic CRPC, roughly a similar patient population, also allowed prior treatment with a next-generation agent, but again, very few had gotten it. So again, a patient population that perhaps is not as common anymore, naive to Abi-Enza for metastatic CRPC. This was an unselected study like PROPEL. However, stratification for HR status was done carefully, prospectively, via NGS and largely via tumor sequencing. The primary endpoint was the same, RPFS, and this study did report a positive RPFS benefit for the combination with a hazard ratio shown here on the left at 0.46. This is a slide from GeoASCO. And in the HR non-deficient group that was prospectively identified, unlike magnitude, there did appear to be some benefit with a hazard ratio of 0.70. However, overall survival data was immature despite this overall radiographic RPFS benefit. And I just want to say that the combination, they did report some substantial anemia. So a grade 3, grade 4 anemia was occurred in about 45% of subjects. So that's not nothing in terms of toxicity here for this particular combination. So to summarize, there's some preclinical data in some prostate cancer models suggesting that AR inhibition blocks HRR, and that AR inhibition and PARP inhibition may have a synergistic effect on prostate cancer growth. But again, it's unclear whether these prostate cancer cell lines represent non-HR metastatic CRPC. PROPEL showed an RPFS benefit in unselected first-line metastatic CRPC that was largely naive to next-generation hormone agents for the combination of abiraterone and olaparib, but determination of HR status was exploratory here. Nonetheless, the European Medical Authority approved the combination based on these results. It's unclear at this point whether this finding would hold in a population that's already received a next-generation hormonal agent for castration-sensitive disease. Conversely, magnitude showed no RPFS benefit in the HR non-mutated first-line metastatic CRPC population for the combination, and this was done in a prospective way, whereas RPFS benefit was observed in HR mutated metastatic CRPC. So really, these are conflicting results. Final results from TALAPRO-2 are expected, and I just want to add that, of course, toxicity is also important, and the addition of PARP inhibitor to ARSI is associated with increased toxicity. In TALAPRO-2, it was about 45% grade 2, grade 3 anemia, but in general, any grade anemia will be greater than 40% with the addition of PARP inhibitor to a next generation hormone agent. And I would just say that although this combination is approved based on PROPEL in Europe by EMA, we do not in the United States have a approval for the combination. It is not a standard of care based on any of these studies at this time. And I'd like to end here. Thank you very much.
Great. Thank you very much, Dr. Abida. I think it was very interesting is unfortunately we can make applause, but virtually there's applause from the audience. We would like obviously to have these webinars as as much as interactive as possible. That's why, you know, I've been seeing that there's a box for you attending the webinar to make questions. So we'll be actually asked then to pick them up and then forward to the speakers. I don't know whether Jocelyn, you want to say anything? We got a minute, please.
Okay, so thanks a lot, Wasim, for this nice talk. So I will expect some questions from the participants, and I will probably start. Yeah, okay. The first one is, could you please comment on the release on Triton-3?
Yeah, of course. So I'm happy to comment on Triton-3. I didn't mention it here because it's really an extension of Triton-2, as that is looking at rucaparib as monotherapy in HR-mutated metastatic CRPC. So this was not really looking at the combination of PARP inhibition and AR inhibition in the non-homologous recombination deficient population. It was looking to confirm the results of Triton-2. It was designed roughly similarly to the way that Profound was designed. However, it only looked at BRCA2, BRCA1, and ATM, and it found that rucaparib did have an RPFS benefit versus standard of care abiraterone, enzalutamide, or docetaxel in the second line. Specifically for BRCA2 and BRCA1 and ATM grouped together, but really the benefit was primarily for BRCA2. So no surprise, PARP inhibitors monotherapy is effective in BRCA2 mutated metastatic CRPC. That is really the paradigm for PARP inhibitor function, is synthetically lethal when there is definite homologous recombination deficiency. I don't think the results were surprising. Of course, it was reassuring, a good benefit. I would say that the combination of PARP inhibition plus AR inhibition, as presented here, in the unselected population is a bit more controversial.
The next question, so who is the ideal candidate for the combination therapy, PARP plus AR? Or what are the criteria to select a patient for this combination?
I would say that at this point, it's not clear. I do not consider a patient for this combination. Really, we have no approval in the United States, and I do not treat patients with a combination of PARP inhibitor and AR therapy. I would say that there's more and more compelling data that perhaps this combination is appropriate for patients with homologous recombination deficient prostate cancer, like BRCA2s, where across 3 studies at this point, you have an RPFS benefit. I would like to see if there is an overall survival benefit, because an RPFS benefit with 2 active agents for BRCA2 mutated metastatic CRPC does not necessarily mean an overall clinical benefit. Certainly, it's not clear to me that the combination of an AR inhibitor and a PARP inhibitor concurrently is better than the current standard care, which is sequential use of those drugs. But certainly, there's a rationale for using a PARP inhibitor in BRCA2 mutated metastatic CRPC. Outside of that context, the data is conflicting. And although there is an approval in Europe, as I mentioned before, there is not one in the United States. And as far as I'm concerned, it is not a standard of care at this time.
Interesting. So definitely is, as usual, so the current clinical practice is a step beyond, I mean, what respect to what are the design of the studies. Probably we're not expecting maybe that the way this shift, especially nowadays, or most of the ARTAs be used in the hormone setting. So we don't know exactly, first and foremost, as you said, whether to offer this treatment option for patients with DNA repair defects or HRR, or to overall population, and especially which would be the ideal combination with. So this is actually a question that's been just forwarded by another attendee. So how can we fit these data with a current clinical practice, especially in view of the regulatory board still, giving uncertain answers?
Yeah, I mean, I'm interested to hear what others on this panel will do, but as I said before, at this point, I think it's an unanswered question. There is some preclinical data. The clinical data is not conclusive, and so certainly in the HR negative population, I do not use the combination because we know that there's also a downside, which is toxicity, especially for patients who are getting, who we hope and think will be on an AR inhibitor for quite a long time. If we add a PARP inhibitor on top of it, there will be some added toxicity. We know some of the short-term toxicity. We don't fully understand the long-term toxicity. There was a very nice, I think, commentary that was led by Dr. Johan de Bono in European Urology recently, nicely summarizing kind of key opinion on this data, and it has, it's a sort of internationally written commentary, but it's still, I think, an unanswered question in the homologous recombination proficient setting. It's not really clear that the combination should become a standard of care at this time. When the question is unclear, my feeling is at this point, I do not consider it a standard of care yet. Of course, that may not be the opinion throughout.
Just a curiosity, do you expect now with the intensification of treatment in earlier stages to have more patients castration resistant, to have in proportion more HR mutations? So to have a higher proportion of patients that could be actually a candidate for such a treatment?
What I would say is that for specifically speaking of HR mutations, so in later and more advanced disease, there may be some increase in HR mutations or alterations or HR phenotype even as disease progresses, and becomes more heterogeneous. However, if you look at BRCA mutations, which are our best biomarker at this point clinically, our best biomarker for HR deficiency is a BRCA2 alteration in prostate cancer. That appears to be an early event. So there have been several series looking at early tumors from patients with metastatic CRPC, and that appears to be an early event. So it doesn't appear to be increasing in frequency as disease progresses. So I think by and large, the HR phenotype is present fairly early in the diagnosis of metastatic prostate cancer.
Okay. So thanks a lot, Wasim, for this nice talk. And now we have to move to the next talk to have the point of view of a pathologist. So we would like to introduce Maria Tenji from the San Rafael Scientific Institute in Milan, in Italy. So she's from the Molecular Diagnostic Laboratory Pathology Unit, and she will talk about the link between DNA repair pathways and their impact in prostate cancer and all the molecular assay that we can have for this to study DNA repair pathway in prostate cancer. So welcome, Maria.
I'd like to thank the organizer for this kind invitation. And I will talk about homologous recombination defect and how they can be studied for diagnostic purpose in prostate cancer. So I have no conflicts of interest to declare. As you already know, alteration in DNA repair gene have been found in patients with metastatic prostate cancer. And these alterations are found at somatic level in 23% of metastatic castration-resistant prostate cancer. And the frequency of DNA repair alteration increases in metastatic disease versus localized disease. And this the already known paper in Cell of 2015 that show how the most frequently mutated gene is BRCA2 followed by ATM and BRCA1. At germline level, it has been shown that 12% of men with metastatic prostate cancer have germline DNA repair defect. And you also see here how the most frequently mutated gene is again BRCA2 followed by ATM. And BRCA defects have been associated with poor outcomes in prostate cancers. As you know, the study of HRD and response to PARP inhibitors began in ovarian cancer showed durable clinical benefit, and for which olaparib was FDA approved in 2014. This is the first study in 2015 suggesting that PARP inhibitor olaparib has clinical anti-tumor activity also in metastatic castration-resistant prostate cancer with HRR defects. Based on this encouraging result, the phase 3 PROFOUND trial of olaparib in CRPC was designed. And as you say, in May 2020, based on the data from the PROFOUND study, the FDA approved olaparib for treatment of CRPC patients with pathogenic germline or somatic mutation in HRR genes. And always in May 2020, based on the data from the TRITON2 study, the FDA approved another PARP inhibitor, rucaparib, for the treatment of CRPC patients with BRCA1 and BRCA2 germline or somatic mutations. It was also suggested that not all the HRR alterations are equal in terms of PARP inhibitor response, but the response is predominantly for BRCA mutation, as we already heard. The FDA mentioned germline or somatic variant testing, but what does it mean? What are the differences? For a germline variant test, we use peripheral blood, and constitutional variants are identified. DNA is extracted from peripheral blood. The subject may be disease-free. The aim is to identify families with hereditary malignancies, and they are detected only germline variants. For a somatic variant test, we use tumor sample. Tumor variants are identified. DNA is extracted from tumor tissue. The subject has the neoplasia. The aim of the test is therapeutic or prognostic, and both somatic and germline variants are identified, but it's not possible to distinguish between them. So, this means that if we perform a germline test for therapeutic purpose and it results negative, we have to perform also a somatic test on tumor tissues. And if we perform a somatic test and it results positive, the therapeutic purpose is satisfied, but we need to proceed to perform a germline test in order to know if the neoplasia is hereditary or sporadic. The tumor sample that we use for somatic tests are FFPE samples for either surgical specimen or small biopsy. Cytological sample can be also used. It is important to keep in mind that the quality and quantity of DNA extracted from FFPE are inferior than the ones extracted from fresh tissues. And PCR amplification failures can occur. Furthermore, tumor tissue sample can have a variable percentage of normal cell with no alteration, and this leads to an allelic frequency reduction of the detected variants. For this reason, the sample for molecular analysis must be evaluated by a pathologist for determining accurate percentage of neoplastic cells. In our lab, we use an NGS approach for BRCA and HRR tumor tested, and we validate tests for both BRCA and 19 HRR-related genes. When we evaluating BRCA and HRR-related genes, we identify homologous recombination deficiency by looking for the cause of the HRD. But we can also evaluate HRD by the fact that HRD produced on the genome by looking for genomic instability. And genomic instability can be analyzed by investigating the loss of heterozygosity, the telomeric allelic imbalance, and large-scale state transition. The combination of these three parameters of genomic instability provides the so-called HRD score. This double approach has been extensively studied in ovarian cancer, and the first test was developed by Myriad, and it was largely used in clinical trials as centrally performed test. In the last years, locally performed HRD score test has been developed, and we validate this type of approach by using the amyloid X in our lab for ovarian cancer And we found a complete concordance in HRD status detected by the Amoy and the Myriad assays. There are still just few reports for HRD score in prostate cancers. In particular, this paper described that germline BRCA2 altered cases have significantly higher HRD score than germline ATM and JAK2 cases, consistent with the lower efficacy of PARP inhibitor among the latter. So this preliminary analysis suggests that higher HRD score may potentially be associated with improved clinical outcomes to PARP inhibition in prostate cancer. We just began to evaluate HRD in prostate cancer in our lab, and here I can show you our first result obtained in 3 aggressive prostate cancers with introductory and cribriform histologies, high Gleason score, high stage, microsatellite stability, no mismatch repair defects. All of them had high HRD score, meaning that they had genomic instability. Looking for the cause of such an instability, we found by utilizing the HRR test, we found in one case a BRCA2 mutation. The other 2 cases were wild type for the HRR tested gene, and therefore on this tumor, we are now performing a wider NGS analysis using a panel of 500 genes. So summarizing, we can say that prostate cancer has a high rate of actionable germline and somatic pathological variants. HRR gene pathogenic variants have therapeutic implication, and tumor testing can detect simultaneously both somatic and germline variants. The response to PARP inhibitor is predominantly for BRCA pathogenic variants. HRD score, the score of genomic instability, characterized the effect of HRR variants on the genome, and it was shown to be high in prostate cancer with BRCA2 pathogenic variants. And I just want to leave you with this open question. Could HRD score be used in prostate cancer as predictive biomarker as we do for ovarian cancers? So let me thank the people that work with me, and of course you for your attention.
So thanks a lot, Professor Frangi. So the talk is open for questions, so we can have a look on the question and response panel.
Well, I have a question. While people probably is thinking about, and my question is about, you've been suggested that maybe the controversial outcomes in the papers shown by Dr. Arida could be because not all the mutations were possible to be detected or were unknown, but could be actually somehow a misclassification because a somatic a mutation hadn't been checked properly. So actually, what would be, Dr. Kanji, from your point of view, the way in which nowadays a castration-resistant prostate cancer patient should be managed? So in other words, whether a blood test should be done to test whether it's got BRCA mutation or HRR, or should actually be increase the number of patients they should undertake a biopsy of most relevant metastasis, for example. Thank you.
You're welcome. I think that one way to look at this situation is to try to understand if a mutation is really affecting the genome and gives an HRD phenotype. So looking at this situation in tissue for sure can help more than in blood as germline testing. I'm not speaking about the liquid biopsy, okay? I'm speaking about germline testing versus somatic testing. So having a double approach of the problem for sure can bring to identify more patients that are HRD deficiency and that can hopefully respond to a PARP inhibitor treatment. That is what I think.
I add to that, I appreciate Dr. Kanji's answer. I think, I have to agree with that. First of all, bringing the question of liquid biopsies, because that was one of the issues that could explain some of the differences. So there are limitations to liquid biopsies. They do fail to identify, they're unable to identify certain types of deleterious BRCA somatic mutations, not germline, but somatic mutations such as deletions. That is a real limitation, and they're highly dependent on tumor volume, which is particularly relevant in earlier disease. So when there's less metastatic disease, they are more likely to miss certain type of mutations. So there could be a misclassification, or at least the risk of misclassification is higher. Our preference when there is a tissue sample available is to do NGS on the tissue, because we have less purity issues related to the tissue sample. And then secondly, what Dr. Kanji mentioned, the development of homologous recombination deficiency assays rather than just looking for BRCA, I think ultimately is a promising area that hopefully will be able to better classify patients into HR deficient or proficient. It's still in the development phase, but hopefully will help to elucidate some of the differences among the studies that we're looking at here.
Very interesting.
A question about what way is better to detect homozygous losses of tumor suppressor genes in BRCA2 plasma?
Dr. Kanji, I don't know if you have a comment, or I'm happy to answer as well clinically how we do that here.
Yeah, you can answer, because I don't know a lot about the approach of liquid biopsy, so we don't use that.
So we don't do it in liquid biopsies. So liquid biopsies, again, really rely on a very high tumor volume to identify certain types of alterations. They can detect sort of truncating mutations, point mutations, stop codon mutations. However, they rarely can detect homozygous loss because you require a very low background essentially of normal genome to be able to detect deletions. So in order to identify homozygous loss of BRCA2, then you really, in general, need a tissue sample. And even in that tissue sample needs to be of good enough quality and high enough tumor purity to identify the homozygous deletion. Now, why is that particularly relevant? Because it turns out that patients with homozygous loss of BRCA2 tend to have the longest and deepest responses. And so if you miss those, and classifies them as homologous recombination proficient when they actually are deletions that can respond the best, you can imagine that those can really skew your results, right? If you're including patients with BRCA2 homozygous loss and counting them as homozygous as HR proficient, they're likely to have the best responses. So they're going to skew your results substantially.
Very good.
So let's say that we have to use the liquid biopsy just in those cases where really we do not have tissues. That is the major point.
At this time, I would agree with that. That's how we're doing it. And the technology is improving. Sensitivity of liquid biopsies is improving. But at this time, our practice is still to favor a recent tissue sample whenever available.
Okay, so anyway, so just to recap, are you increasing the recommendation of your clinical practice, the somatic, the tissue sampling in supporting the targeting treatment, or guiding the?
We generally do that in diagnostic as a diagnostic purpose. What we want to understand if we can use also the HRD score to help this definition. That is our things that we are working on now.
I see. Okay, so I mean, there are many questions, obviously, that may rise, and there's maybe we are a little bit beyond the time. Actually, it was just a comment. So maybe we should move on with the next presentation. First, I wanted, before to introduce Professor Fanti, I wanted also to thank the ISU, Professor Liatzikos, and all the team, the central office as well. And obviously, this is a webinar which has been organized in combination between the section I chair, the ISY, and the section from Uropathology and Urology Research, chaired by Professor Kolekia and Yuki Kirsten. So now is the time for actually another type, fascinating field of the target treatment in prostate cancer, is a theranostic in advanced prostate cancer, and the audience is yours. Stefano, Professor Fanti, thank you for joining us.
Thank you very much, Francesco. It's my great pleasure to be here. Sorry, I started the wrong slide. I hope now it's correct. Again, many thanks to the attendants, to the organizer, to Francesco, EAU. These are my disclosures. As I used to say, my main disclosure is that I'm proudly a nuclear medicine physician, so be ready to listen to a talk with a nuclear medicine perspective or point of view. And theranostic, you know, it's nuclear medicine. So this definition is stolen from Wikipedia, which is one of the most frequent research right now. And what is theranostic? It's not just a trendy and fancy word, but it means that it's a process of diagnostic therapy. So you put together diagnosis and therapy in order to have an individualized patient test and predict if they can respond to a specific therapy. So essentially, you do identify a target. Now, if you think that this red is a very mean cancer cell, you know, there are many targets overexpressed in cancer cell, and you can try to target them using an agent, a link, and then you can add a radioactive isotope. Now, if the isotope is emitting, for example, gamma or even beta positron, just like gallium and fluoride, you can see the cancer. So you can do diagnostic, you can do imaging in vivo. If you're replacing the isotope with a killing agent, just like an alpha or a beta emitter, that could be lutetium or yttrium or actinium, and we have many others, then you can treat the cancer. So essentially, as a function of the isotope that you're using, you can be either diagnostic or therapeutic. And the combination of the two is theranostic. That's say that you see and then you treat. Now, theranostic is quite a new and trendy word, as said, but it's definitely not a new concept at all. Indeed, the theranostic of thyroid cancer was introduced in the 40s because of the special characteristic of a thyroid cancer cell to incorporate iodine. There is a specific symporter, and it's been used either for diagnosis and for treatment of thyroid cancer with great success since the mid-40s. So it's definitely a very long story. But indeed, the real success in clinical oncology came with the use of theranostic for neuroendocrine tumor. Now, neuroendocrine cells are overexpressing somatostatin receptor, and we were able to have a good ligand which was binding to this receptor for either visualizing, using again gallium, for example, and treating using yttrium and thereafter lutetium-177. So it was demonstrated to be very useful with incredible and fantastic results reported by the NETTER trial and demonstrating the effectiveness for treating neuroendocrine neoplasia. Now we are talking about prostate, of course. We are among urologists, onco-urologists, and so on, which is the target that we are using for prostate cancer. It's PSMA. PSMA is overexpressed in prostate cancer. It's called prostate-specific membrane antigen. To be very honest, it's not super specific of prostate cancer only, but it's expressed also in other forms of cancer. But what it's interesting, it's a very, very good target for therapy. So as said, first you see and then you treat, because you treat what you see. So the first step of theranostic is always imaging. That's to say, if you have a scan, like unfortunately the gentleman on the left, there is clearly overexpression and widespread diffusion of the disease to the bone, and you can clearly consider to treat the patient because of the high PSMA uptake. While the other example, nonetheless, has a terrible number of metastases, but has a very low PSMA uptake. So it's not a good candidate for a theranostic approach. So assessing the rate of overexpression of PSMA is the very first step, and it's crucial before starting any therapy. But what is fantastic is that you have in vivo demonstration of that. So you can really see in the patient which is the degree of expression of PSMA and decide if treating or not on the basis of this finding. So move now on real data on theranostic. And I'm quoting this example from Professor Uwe Aberkorn, a great friend and a fantastic scientist based in Heidelberg. You see the fantastic result, again, on the left before treatment, spread to the bone, and then after therapy with actinium PSMA 3 cycles, an incredible result in a patient that have already been treated with almost every possible therapeutic results. Now, the first patients have been treated with lutetium PSMA 10 years ago, and it was in Heidelberg, again, Professor Aberkorn. You see, treated, first of all, they imaged the patient with gallium PSMA, and then they administered lutetium-177 with a very good result, a drop at PSA, and good clinical response. The first trial was carried out in Germany. It was a multicentric trial. It was not really fantastic, but the design point of view, it was not randomized. So it has a lot of limitation, but nonetheless demonstrated that in about half of the patients, you have a reduction in PSA more than 50% in about half of the patients. A lot of limits, but a sort of first step toward better trials that have been, for example, done in Australia. The Australians are very, very active, and this was a phase 2 trial with 30 gentlemen with metastatic CRPC treated with lutetium PSMA, and the endpoint was simply the decrease of PSA that was demonstrated to be achieved in a significant number of patients. So this was published on the Lancet in 2018, and this has immediately, in conclusion, supported the need for a multicentric randomized trial to compare lutetium PSMA with the standard of care in patients that have already been treated with AD, with ARTA, and with the first-line docetaxel. So that was the trial just mentioned, the very well-known therapy trial published 2 years ago on the Lancet again. It was randomized, run in Australia, and they randomized 200 patients, half allocated to cabazitaxel and the other half lutetium PSMA. The endpoints was a PSA response rate and then secondary endpoints. And as you can see here in the waterfall plot, there was a clear advantage for lutetium PSMA over cabazitaxel in the modification of PSA from the baseline. And there was also an advantage in progression-free survival. So essentially, it was demonstrated that lutetium PSMA was effective in patients with metastatic CRPC, and most of all, fewer grade 3 or 4 adverse events. So it was much better tolerated as compared to cabazitaxel, representing a new effective class of therapy, and so a good alternative. This is the cartoon that they published at the end of the trial. But probably the most known trial is the VISION trial that was published in the New England Journal, again 2 years ago. In this case, it was randomized, multicentric, and it was lutetium PSMA, and the comparator was a standard of care. In this case, the endpoint was more interesting because it was overall survival. Of course, it was also progression-free survival, but you can see there was a clear advantage on overall survival. That was very relevant and associated with some limited toxic effects, so essentially a patient-friendly survival treatment, And this is the final cartoon. This trial has led to the registration by FDA and EMA of lutetium PSMA and incorporation into the guidelines that happened 1 year ago. Here are the EAU guidelines, you see. And in the last line, you see that it's suggested to offer lutetium PSMA in patients pre-treated with metastatic CRPC. And of course, also the North American came to same recommendation about 1 year ago, and it's now available and used on both sides of the ocean. So here we come to some conclusion. As said, theranostic, it's a very interesting approach in oncology. Of course, not only limited to prostate cancer, but definitely in the last few years, prostate cancer has been really a boom for theranostic. This is what we want to achieve and what we can achieve. So we have a patient with very advanced disease that can be effectively treated with the PSMA, either labeled with lutetium or other isotopes. And for example, in these patients, there's been a survival of almost 4 years. It's an approach that allows integration of diagnosis and therapy. It's long been used, and it's in vivo based on personalization of therapy, because you can see the presence of the target. Now, which is the future? The future is clearly related to many trials which are trying to move on an earlier phase of the disease. So not only metastatic CRPC, but also in hormone sensitive or even earlier. So for example, recently at the EU Congress has been reported the upfront or the lutectomy trial, which are trying to use in patients that are not metastatic CRPC. And the alternative could be the use of other isotope instead of lutetium, for example, actinium, which has just been introduced with great results. So the future apparently is very bright, a lot of trials ongoing. And with this, I thank you for your attention. Thank you very much.
Again, another virtual applause for you, Stefano, Professor Fanti, as usual, a brilliant presentation. Any question? Not from the audience, but I can start, asking you what you think about the following. So, that for guidelines, PSMA in the setting of castration resistance is less recommended than in the hormone setting because of the potential mutations or low expression of PSMA in the cells or the cancer cells. So from one side, we have, some studies showing utility of PSMA in this setting. So, but on the other side, also we have this issue, it means, whether we actually may treat, all the patients as they are, for example, from the EMA recommendation, a second line after in castration resistant after chemotherapy. So would be maybe testing somatic test for PSMA useful somehow to stratify patients or not? Which would be the strategy to follow these this recommendation, especially consider the cost of the treatment?
That's a very relevant question. That's to say, we know that despite the fact that you do this in vivo demonstration of the target, nonetheless, a patient with intense expression, so intense PSMA uptake, in about 10 to 20% will not respond to therapy. So you have a relevant number of non-responders. Now, we still don't know how to select them. If it's about genetic profiling, if it's about other biomarker, there's been a number of potential strategy, and none has been demonstrated to be perfectly effective, but all of them may contribute. So I'm fully with you. Ideally, we should select only the patients that will respond to expensive treatment, even if it's really with minor side effects, but nonetheless, it has some. But so far, we don't know how to really characterize them. But that's to say that almost 2/3 of the patient will be responder, which is quite good for a third-line therapy in CRPC.
Dr. Kanji or Dr. Abida, what's your thoughts on this regard or experience, if you have any?
Yeah, I don't have much to add to what Dr. Fanti said. I think it's early days in terms of determining resistance mechanisms. I think this is true for a lot of agents. PSMA expression alone, as detected by a PET scan, does not fully give us the answer in terms of, 100% of who's going to respond. And I think, the potential resistance mechanisms logically are either these are radio-resistant cancer cells, even if you bring the radioactive payload, or there's heterogeneity in the disease, which you're really missing by just doing a PET PSMA scan, which we know occurs, particularly with more advanced disease. You get loss of expression in some subset of cancer cells, and those may be the ones that are progressing. So I think there's just more biomarker work to be done here.
Yep, absolutely, fully agree.
Dr. Kanji, anything to add? We are not listening to you. Maybe you
yeah, I
thanks.
think that the biomarkers are the fundamental step that we need to achieve it. Yeah.
So
Especially
where and how?
Where and how? Yeah. I think that in which type of tissue, and the tissue is the most must be the most used one, because you can have an idea of what's going on. And it's true that it's difficult to have it, but it's where you can really achieve what you wanted. So having the tissue will solve a lot of problems.
The problem is that you may select the tissue on the basis of the imaging. If you're doing a PET PSMA, so you already have a bias there, unless you can check it or challenge the PSMA PET with the conventional imaging.
There are some studies looking at a variety of conventional imaging modalities, and even PET, so FDG PET plus PSMA PET plus AR PET, looking at all of those and looking at the heterogeneity of the disease. And then honestly, it's complicated work. And then biopsying the discrepant lesions and looking to see, what is the level of expression there, or biopsying radio-resistant or lutetium PSMA resistant disease that still expresses PSMA. What are the features of this disease? Clearly, if it's expressing PSMA and progressed, then it shouldn't be an issue of targeting. It should be an issue of cancer cell radio resistance, effectively. Resistance of lutetium as the payload, where maybe actinium would be the right thing, maybe bispecific antibody therapy coming to PSMA. So it's just, I think, multiple complex factors. But I think PSMA PET imaging by itself is not going to be the answer. There's too much disease heterogeneity for this.
So you will be more in offering the patient a combination treatment, like, including, for example, like the loop-up design study, combining PARP inhibitors and lutetium.
That may be, I think that may be. There's promise in combination therapies with DNA damaging agents that includes lutetium and something else. The question always comes down to, they're still phase 1s, right? Because the question is, what is the toxicity of these combinations? Is it just going to cause too much DNA damage to normal cells? But I think there's certainly rationale for combinations of DNA damaging agents. And I think radiopharmaceuticals now offer, I think they're a promising way to combine these agents, as opposed to, say, PARP inhibitor and platinum chemotherapy, which has been too toxic historically.
There's a question from the audience. Do you have any data of the bispecific PSMA that was being developed by Amgen? Stefano, Professor Fanti, this is for you. Question to
well, it's already been, when things got really successful, like it was for, the product for neuroendocrine and now the product for prostate cancer, there are a lot of people trying to follow the same pathway. So right now there is a number of new PSMA ligand and bispecific different isotopes. So it's becoming sort of a race to find the most effective one. In some cases using just the same mechanism, but of course you can play around the affinity, you can play around the residency and the capability to stay inside the cell, you can play around the range of the isotopes to kill the cell itself, or even have a longer pathway. I guess that we are just waiting for the result of phase 3 trial, because as said, even in combination, it's very correct, the comment. In combination in phase 1, it seems to be a lot of advantages for PARP inhibitors or other treatments together with radionuclides. But I think that before having the final data of phase 3 trials, it's just purely hypothesizing things. So honestly, there are so many ongoing trials in phase 2 and phase 3 that I guess it's very exciting to attend any urological or oncological or nuclear medicine meeting to hear about the new data coming from good, robust trials. That's the point, you have to wait for very robust data before spending any conclusion.
Okay, so we have to conclude. So thanks a lot for the formidable, very, very interesting talks. So we can see that the future is promising. We have a lot of trials about combination between PARP inhibitors and AR targeting. We have probably a better understanding of HDR, and probably we have to develop a better biomarker for CRPC. And I really, really enjoy the talk about PSMA and all these trials, and probably we have to understand about the way this gene is regulated during the progression of the disease, and this could be interesting to see the link between AR and the expression of PSMA, and probably we can perform more combination between ARSC and PSMA targeting, and probably maybe also PARP inhibitor. So it was very interesting to have all of this talk, all this information, this data, this new data, and for the future, I think that we can back probably in 1 or 2 years and to make again a webinar on this topic, and to see how probably novel data can improve the strategy for CRPC. So thanks a lot.
Thank you. Thank you to the speakers and to organizers. Thank you all.
Thank you.